What to expect when converting, a walkthrough of clinical data conversion. We'll be taking you through the phases of the conversion and talk about the action items and considerations for each phase. We want to let you know that this webcast might not run the full length, so you might be able to get out and enjoy this sunny afternoon a little bit more. Your phones have automatically been muted. If you have questions during the webcast, please post them in the Q&A panel. At the end of the webcast, we will look at your questions and answer what we can during the webcast. Let me introduce you to our presenters today. My name is Mark Hanrahan. My current role is Conversion Clinical Analyst. We'll also be hearing from Aaron Michaud, who is the Lead Conversion Clinical Analyst, and Elise Brault, who also works as a Conversion Clinical Analyst. So what is a clinical data conversion? A clinical data conversion is the process of extracting clinical data from one system and loading the data into another system. The system the data is extracted from is referred to as the source or legacy system, and the system the data is loaded into is referred to the target or new system. There are two main reasons to have a clinical data conversion. First, conversions are needed when healthcare organizations acquire one another, and clinical data is different in different EMRs, and they need to be merged into one system. The second reason is when a healthcare organization decides to change from one type of EMR to another, and the data from the legacy system needs to be brought over to the new EMR. The conversion process takes a team of technical and subject matter experts. Galen's conversion teams are broken down as follows. The technical analyst extracts the data from the legacy system and formulates the data to be loaded into the target system. The clinical analyst is the project manager for the conversion. They do the mapping of each data element from the source system to the target and participate in the testing and validation of the clinical data. The technical analysts and clinical analysts work together to resolve issues that come up during the testing phases and communicate closely on all decisions made through the conversion process. The analysts use lessons learned from the past conversions to recommend strategies and decisions the client needs to make. The client side of the conversion team needs the following. The team needs an identified decision maker for all the decisions that will be made throughout the conversion lifecycle, related to things like scope adjustments, timelines, and processes. The client needs to have the technical resource to help with the system access and someone responsible for working with the interfaces between the systems. A clinical resource on the client side validates the clinical mapping done by the Galen conversion team and participates in the testing and validation of converted data. We recommend that the clinical resource be familiar with the data being mapped. For example, it's best to have lab orders validated by someone familiar with the client's lab compendium. A conversion has 6 phases: the project design, extraction, and data evaluation, data mapping, testing and validation, conversion go live, and the support and gap loads at the end. For the remainder of the presentation, we'll be going over each phase in detail, looking at the action items and considerations for each phase. The first phase is the project design. The conversion project begins with a client and a kickoff meeting to review the details of the items and scope for the project. The review provides the opportunity to ask questions and make clarifications so all parties can sign off on the plan of the conversion. The clinical analyst uses the refinement and clarification of the project scope to develop the project plan. The kickoff call is the time to make sure the process for dividing access to the databases and the systems for the conversion team has started. These processes need to be started as soon as possible because it often takes longer than expected, and the actual conversion work can only begin after the system access has been granted. The overall scope of the project is determined when the statement of work is signed. However, a couple of examples when further details are needed would be patient demographics. Should deceased patients be converted? Another example would be test patients in the source system. Should they be converted to the target system? Or in addition, encounters. Are all encounters in the source system going to be converted, or only encounters tied to clinical data that's in scope? The timeline for the conversion needs to be considered as well. Depending on which kind of EHR is the target system, there will be different testing requirements that impact the schedule. In addition, decisions made about the number of rounds of testing will affect the timeline. Some conversions can take up to 8 months, and others will take up to 4 or 5. The client has a conversion team as described, but they will also bring other resources in during the conversion that they will have to make plans for. For example, the last round of testing uses people that will be actually using the target system after the conversion. The availability for these testers needs to be planned for at the beginning of the project. The next phase in a conversion is extraction and data evaluation. The technical analyst extracts the data and scope from the target system so that every item can be mapped to an equivalent in the target system. The technical analyst creates mapping workbooks for each data type extracted. The extracted data will be analyzed and specific questions or scoping details will be addressed. The technical analyst will use the mapping workbooks to configure the import files for the target system. During the data analysis, many decisions are made. Some examples would be, if an immunization requires an administration date in the target system, but it is not required in the legacy system, the decision needs to be made to manage this discrepancy. For this situation, the Galen conversion team usually recommends that the immunization be loaded into the target system with a generic administration date. That makes it obvious that the date is not relevant. For example, 1/1/1900. The field is populated, but end users will know it's not a real administration date. Another example concerns providers. If a provider is inactive in the source system, the question becomes whether or not to build a provider in the target system. Again, the client will decide, but we would recommend that one default provider in the target system be built and used for all inactive providers coming from the source system. A decision needs to be made on what note status to bring over from the source to the target system. Usually, only signed and finalized notes are brought over, but a client may have a reason to make a different decision. Some data that's clinically important to the data in scope cannot be converted because it cannot be mapped to an equivalent data element in the target system. A decision needs to be made as to whether or not the data will be placed in the comment field or the data element in the target system, or if a document needs to be created to capture the information. Now I will turn the presentation over to Erin to talk about Phase 3.
Thanks, Mark. I'm going to start by talking about Phase 3 data mapping. In order to convert data from one EHR to another, the data will need to be matched up between systems. Each system will have its own individual codes and descriptions for the data elements, so mapping needs to take place. Data mapping consists of matching each legacy record for a given data element to a record in the target system. Once the tech analyst has completed extracting the legacy and source data and compiled the data into mapping workbooks, the clinical analyst will start mapping the data from one system to another. Usually the clinical analyst will map one data element at a time. Once they have completed the first pass of mapping, they will work with the client to review the mapping and fix any issues. Here I have listed the types of data that a typical conversion would include. Besides mapping the major data elements such as labs, vitals, transcriptions, we also need to map the data that is associated with these major data elements, such as departments and providers. Depending on the target system, there may also be a need to map descriptive data within the major data elements, such as statuses for notes and problems, allergy reactions for allergies, and routes and units for meds and immunizations. Okay, so there are a few items that will need to be discussed before and during the mapping phase of the conversion. These considerations will make the process more efficient, and save time in the long run. As I said before, the clinical analyst will complete the initial mapping for each data element, but the client will need to review and sign off on the mapping. Before getting to the mapping stage, it's important that the client assign clinical resources or IT resources familiar with the data to validate and sign off on the mapping. These people tend to have really busy schedules, so the clinical analyst should schedule time to review the mapping with them prior to this phase. The clinical analyst should also be able to provide time estimates on how long the review of the mapping will take them. During the initial mapping and client review, people may find certain records or data elements that they don't want converted to the target system. For example, I have had conversions where the client realized that the medications weren't accurately being entered into the legacy EHR, so they decided not to convert them to the new EHR. I have also been involved in multiple conversions where certain scan types are used for miscellaneous or non-clinical scan documentation. The clients made decisions not to convert those since they weren't needed in the new system. Once the client has made a decision to exclude certain data elements or specific records, our tech analyst can easily remove this data from being converted. Mapping is probably one of the most time-consuming tasks within a conversion. Some organizations may have thousands of results, medications, problems that need to be mapped. One thing that clinical and technical analysts can help with is to find ways to automate this mapping. We can often use universal IDs or patterns within the data to help automate the mapping, such as using RX norm codes for medications and allergies, or ICD-9 and 10 codes to help map problems. Sometimes, if the hospitals or clinics use the same lab system, we can find patterns between the interface identities and the EHR codes. These are just a couple examples of ways we can automate the mapping. So I recommend taking time to look at the data as a whole to find ways to automate the mapping. This will ultimately save time for the entire project. Okay, sometimes, however, even with automating some of the mapping, the client may also decide to limit the scope to reduce mapping times. Some target EHRs allow for us to import unmapped records and have the end users reconcile the data when they are in the patient's chart. If this is the case, we often recommend that we don't map anything under a certain number of occurrences from the legacy system. This technique usually saves a lot of mapping time and will have a small impact on the end users. An example would be that they wouldn't map any problems, medications, or allergies that have less than 10 occurrences in a legacy system. Then we would convert them to the target system, and the end users would reconcile the unmapped data to the new chart. Any possibility to limit mapping time, another possibility to limit mapping time is to use a CCD, or continuity of care document, to convert certain data types. A CCD is pretty much a patient summary report that will be shared between EHRs. Certain EHRs have the functionality to pull in specific data types from the CCD. So, while seeing a patient, the provider or nurse can reconcile the CCD with the patient and pull in their data. Usually, it's problems, meds, and allergies to the new EHR. The data mapping is either done behind the scenes with universal IDs, or the end users picks a correct match when reconciling the data to the patient's chart. Even with the ability to automate mapping and using other techniques to reduce the mapping time, there will always be legacy data that we can't find matches for in the target system. This is when the clinical analyst will work with the client to decide if new records should be set up in the target system. We find that this most commonly occurs with imaging and lab results. The client will need to make a decision on whether to build equivalent matches or maybe decide not to convert those records at all. If creating new builds for these items is the answer, the client should also make sure they have resources available to help build the new records. Okay, so now I'm going to talk about phase 4, testing and validation. Once the mapping is complete and signed off on, the next phase of the conversion is testing and validation. We often split up the testing into 4 phases. The first phase is unit testing. The unit test consists of testing one message for each data type being converted. This is to make sure that the import format is correct and that all the clinical content is being converted for that message. The next phase is small-scale testing. This usually consists of picking a small sample population of 5 to 20 patients and converting the data for these patients. Usually only the clinical analyst will be involved in this testing, but if the client is anxious to see the data, then they can help as well. The next phase is large-scale. Large-scale testing would typically include converting one message for each record mapping within a data type. For instance, if you mapped 50 immunization records from the legacy system to the target system, we would convert one message for each of the 50 records mapped. This just ensures that you're testing every single mapping. We have also done conversions where large-scale testing consists of selecting a large sample population, usually a percentage of the overall patient population. We typically select patients with large amounts of data in their charts, so we'll have more to test with. Large-scale testing will involve the clinical analyst as well as the client. Usually the core project team will help with the testing as well, such as clinical users, physician champions, or super users. The last phase of testing is full-scale testing. Depending on the target system and the client preference, full-scale testing may or may not be required for the conversion. During a full-scale test, all the patients and clinical data are converted to the test environment. It's kind of like a dress rehearsal for go-live. Full-scale testing typically involves the clinical analysts on the project coming on site to work with the end users to validate the data. There's usually about 2 to 3 rounds of full-scale testing, and it takes about 4 weeks to complete one round of testing. This includes setup, coordination, the actual testing, and issue resolution. So, the planning and preparation for testing can be quite involved and will need to be discussed prior to this phase in the project with the client. One thing that can be discussed early on in the project is the testing environment. There will need to be a review around the client's current testing environment configuration. The main concern is to make sure that the testing environment you are using for the conversion closely reflects the production environment. If the testing environment is out of sync with production, then the test data could potentially not reflect what the data will look like when converted to production. We usually recommend that the testing environment be refreshed to reflect a recent copy of production early on in the project. Another early consideration is how the testing patients will be converted to the testing environment. If there's an ADT interface, we often recommend pointing it at the testing environment to convert the patients. Or if the patients are already in production, refreshing your testing environment using a copy of production will ensure that the testing patients will be in the testing environment. If the clinic decides that they want multiple rounds of full-scale testing, planning will need to be done to make sure that the testing environment is refreshed between full-scale testing rounds. Since we are converting all the patient data in one round of full-scale testing, in order to do another, the testing environment will need to be cleared of the previous converted data. So, depending on the type of EHR and setup, it could take some time and resources to refresh this testing environment. So along with the resources needed to configure the testing environment, we'll also need to schedule testing resources to do the actual validation. We recommend involving a wide range of testers to validate the converted data. We suggest, especially with large or full-scale testing, that the end users, or at least the clinical users, be included in the validation. A client may also want to involve their IS resources and managers in the testing. Overall, it's important to include people who are familiar with the data and the workflows in the target system. This is also a great way to start the training with the end users. If they're validating data in the new environment and they haven't used it before, they'll be able to actually see what the data will look like and begin to get familiar with the new AHR. As you can probably tell already, there's a lot involved with the validation phase. The planning and coordination can be very time-consuming and extensive. Some conversions may even staff a testing coordinator on top of the clinical analyst to help with the testing phase. So, as you can tell, planning ahead is essential. The preparation for large and full-scale testing may take up to 1 to 2 weeks prior to the actual testing. Okay, now I'm going to go over some items that will need to be considered before the full-scale testing round. All these recommendations come from previous experiences with conversion validation. To start with, we recommend that when validating, the testers have access to both the legacy and target systems, so they can actually compare the data in one system to the converted data in the other system. This would require that they have logins to both systems, that they are computers set up with connections to both systems, and that the validators have dual monitors, so they can compare one monitor to the next. Depending on who will be doing the testing, scheduling the testers to validate can take a lot of preparation. As mentioned before, resources and end users usually have limited time away from their regular jobs, so validation schedules should be worked out ahead of time. If end users are involved, it may also mean finding coverage for them at the clinic or the hospital. Testing location can also be something difficult to coordinate. We recommend that the testers not be at their personal desks or offices so they aren't distracted during testing. We often suggest setting up a temporary area or maybe repurposing a training area to do the testing. Scheduling rooms and setting up the testing area may also be difficult due to space constraints, so make sure you schedule this early on. So after testing is complete, the issues will need to be consolidated and reviewed. Prior to testing, it should be decided how the testers will record issues during validation. We often provide clients with paper test scripts, which we then consolidate into an electronic document when testing is complete. Usually the core project team will review the issues list, assign out tasks, and retest the issues once they have been resolved. This process, however, should be worked out ahead of time with the client, with special attention to how and who will be doing the retesting and sign-off of the issues. Okay, now I'm going to hand off the presentation to Elise, who will be talking about the go-live phase.
Great, thanks Erin. I'm going to finish up our presentation today by talking about the final 2 phases of Galen's conversion methodology, which are 5, conversion go-live, and 6, post-go-live support. And then as part of that, I'm going to go ahead and cover the concept of gap loads that's been mentioned in the presentation prior to this time, so we'll make sure that you understand what we mean by gap loads. So first off, I just want to start off by saying that the way we are presenting this information to you, outlined in phases like this, suggests that each phase concludes before the next one begins, and that is certainly a true statement for many aspects of these projects where the initiation of one task is dependent on the successful conclusion of another. But for go-live planning, I just wanted to point out that although we are showing it here as a distinct phase, the planning for go-live begins much earlier in the project timeline, and actually you could say even at the onset of the project, because as soon as conversations begin with the client team, then the tracking of issues and decisions that impact the conversion go-live begin collecting as well. But going with the idea of conversion go-live phase as a distinctive sequential phase, then at a high level in here, one of the deliverables we are looking for is the creation of a detailed checklist. This checklist will basically serve as the guidebook for outlining and tracking everything related to the conversion that must be done, either as a prerequisite for the go-live kickoff, or done as part of the actual conversion, or as follow-up to the big event. On the technical side, the Galen IT resource will be using the feedback and issues reported from testing to refine and tweak the conversion import files for the client's live environment. Next, the plan for the communication during the conversion will be worked out, and often, just in the name of efficiency, this can be embedded right into the go-live checklist. And then finally, as part of this planning and review, a specific timeline for go-live activities will be vetted out and documented also. Again, sometimes helpful to have that right within the checklist. Some things to consider while planning for go-live include information gathering and tracking any decisions that are made by the conversion team leading up to the conversion. So some of these particulars would have been framed up in the statement of work, or SOW, and reviewed as part of the kickoff call for the project. An example of this would be if the SOW stated that only verified results will be converted and that they would be the only results considered in scope. Well, if that's the case, then there would need to be a go-live action item track to make sure that, for example, providers verify all outstanding results before the source system is taken offline for the conversion. Or at a minimum, the client would want to discuss an alternate plan with their lab vendor. Either way, an issue such as this one would need to be tracked and discussed as part of go-live planning. Sometimes during data mapping, peculiarities, let's say, with data from the source system are uncovered by the tech team. These items are usually brought forth in the weekly status calls, and then any decisions made by the conversion team over how to convert the data. These decisions will need to be tracked and have the potential for having a significant impact on the go-live, actually. For example, in my last conversion, we uncovered a theme with the legacy EHR data where many free text entries of all different types of clinical data was permissible. And these data elements each had a unique code and description, and this made them very difficult to map over to a discrete entry in the target system. So after much review and discussion, part of the solution led to technical work in the form of creating a conversion summary document that could capture certain results data and then would display in the target EHR as a scanned document on the patient's chart. And this decision, in turn, uncovered the need to support staff and end users on the conversion data specifically because it was different. We needed to make them aware of how they would be seeing results data in the patient's chart. Another example of this was with active problems in past medical history in the legacy EHR not clearly designated as to which status they were, active or past medical, depending on how they were entered. So again, through the conversion testing, we discovered this, and it gave the appearance in the target EHR of these problems being all mixed together, and there really was no way around that in the conversion of the data, so it became a training issue, something that we need to bring forth to the participants in the go-live and the support afterward. Another very important way in which issues are raised and must be tracked is through testing. Many issues uncovered, what am I doing here, sorry. Yeah, sorry, I just was recapping a sentence here. They have issues have the potential to impact planning for go-live. One thing I wanted to point out in our last conversion was that we had an issue with MU statuses for smoking and family history. We found that the way that they had been entered in the legacy EHR really couldn't map over to the target system in the MU compliant selections that have, most people are aware of what they need to be, and even create like order folders in the EHR for that very specific purpose, basically. So one of the training issues that we had was to make sure that staff were trained, basically, to make sure that they knew that they had to transition the problems coming over for smoking status to the new MU-compliant smoking status entries, and also to make sure that the family history was documented with the first-degree relative. Again, another requirement for MU. So we've talked a little bit about the need to train support staff and end users on the conversion data and gave some examples there. Sometimes this aspect of the conversion can be easy to overlook, as the focus is usually pretty intensely on the data aspect of the conversion. Typically, it's the client who pulls the training plan together and executes the training, but Galen does have experienced resources who can assist with this as well. At a minimum, making the conversion documents, which are the decision document, mapping workbooks, and issues lists, things that came out of testing, making those documents available in a central place, such as a folder on a conversion server, is a good idea, as these can be very valuable for reference. And then one more mention here, it's helpful to understand from the client whether the legacy EHR application will be available to end users at all post-conversion, even if in just a view-only capacity. Knowing this can just help direct whether it will be necessary to guide the clients to preparing any reference materials or paper printouts or whatever that might be. So So timing of test import files. When converting data into the test environment, the Galen tech can time how long the imports take, especially with the large files such as results and scanned documents. We typically find that those take quite a bit of time or have the potential to. I will make a quick mention that Galen does have some conversion tools, some already implemented and some in development that can help expedite this process, but nonetheless, these can take quite a while. So the timing in test is important. The team can then use this information to put shape around the conversion timeline for live. For example, discuss things like, is there any flexibility with when the start of the conversion can happen? For a weekend, let's say, we know the files are going to take quite a while to load. Could we start the conversion on a Thursday night versus a Friday night, as an example? Lastly here, I guess I have one more after this too, interfaces. As part of go-live planning, it's just important to bring in the vendor representative to work out the cutover plan for the interface from the legacy EHR to the target EHR. Some considerations that need to be worked out include when will the last round of results be pushed to the legacy EHR, and will the timing of this allow for any subsequent results verification to be done, as we have previously discussed, if that's a requirement. Another question to ask, will end users be off the legacy, when will end users be off the legacy EHR application? And then what's going to happen with results, for example, over the conversion downtime? Are they going to be electronically queued up, or are they going to be printed and faxed over and then scanned into the target EHR post-conversion? And one good question to think about is, are there going to be any potential issues with identifiers such as patient MRN numbers or any other order identifier or result identifier that will need to be bridged post-go-live? Often there can be issues where, after the go-live, we can't make the match electronically. It needs to be done manually. Now we get to our last one here on this slide, and that's dependencies. Always important to keep an eye on are those tasks that must be completed within a certain time or before another task can be completed. So on a big note, it would be, import files must be created before the conversion can be done, of course, but there are lots of small examples to keep track of too, such as the results verification we already talked about. Another example would be identifying whether tasks, such as med renewal tasks that might be coming in electronically even, whether they need to be worked prior to conversion. If there are reminders in the legacy system that the providers would like to have access to, do those need to be rebuilt in the target because they're not going to be included in the conversion, for example? Those are just a couple more examples from my experience that should be discussed and understood. So just to reiterate on the slide here, from the beginning of the project time, the analyst or person acting as the PM will collect and keep track of all of these open issues, including the things to remember and address during the go-live planning. I find that one easy way to do this is right on the weekly status call agenda. I figure, every week we're getting together, we're looking at the agenda. Why not keep everything in one central place and even review on a pretty frequent basis as that list is growing to make sure that we're giving it the due time and process that you certainly will need to with some of these issues. So now on the screen here we have a sample of a conversion checklist, and at least from my perspective, the goal here is not to try to create a big laborious document that people have to struggle to follow along, but we also want to capture a pretty specific level of detail so everyone knows what's supposed to happen and also the dependencies we have talked about. So I'm just going to go through a couple. I'm not going to read each line here. I'm sure you're happy to hear that, actually. The second item down on the list is completing the gap mappings, and I am going to kind of park that topic as far as explaining what it is, but I do want to make a mention here that basically this checklist illustrates that one way in which gap mapping can be addressed, and there are lots of ways, but in our example here, the client wanted to minimize the effort involved over the conversion weekend in this example. Not all conversions are over weekends, but and so in this checklist here, this client opted to do the gap mapping, gap analysis before the conversion, and then spend this week prior to go live actually taking care of this additional mapping and then leave very little for the conversion itself. So another thing I wanted to point out here is the communication plan. We talked about that as one of the elements that needs to be worked out as part of the planning. So you can embed it right into the checklist if that works fine. Specific intervals of communication have been planned in this example here over the conversion week and weekend. One thing that isn't really on here that you often see with any kind of conversions or upgrades is a database backup. That's really a client decision as to whether or not they feel there's enough risk to merit a database backup. In the example that we have here, the client decided that, unlike an upgrade where you're changing the actual application and features within, with a conversion you're just pulling over patient-specific data, and they felt that the time invested into the database backup wasn't time well spent, and so they opted not to do that. But yet again, another example of something that can be talked about and worked out with the client. So the second part of this list here, basically just a couple mentions, the validation of the conversion data during the actual conversion. That scope is usually defined by the client. And I know Aaron, talked earlier on in the planning of this what that would entail, but essentially prior to the conversion, the client can think about their entire population of patients, how much data is being converted, and what they feel comfortable with as the measure for what needs to be validated over the conversion period to say, yes, this was successful. I also want to point out that typically there's, as far as communication goes, begin and end day status emails. That's very helpful so people know if you've got some testers on standby, for example, when can they come in, what's left to be done, is it going to take the entire whatever time period, 2 or 3 days, or is it going along better, or is there a delay of any kind? Is very helpful. And then set status calls, basically, usually in the mornings, each of the conversion days, and then a call post-conversion, just to check in on any issues, because of course, as Aaron has mentioned, over the conversion, testers are documenting issues, and any issues that are not resolved are going to be dealt with in a post-go-live manner. So let's move on to phase 6. This is support and gap loads, basically. Go-live support may be specified as part of the client's SOW, or it may be negotiated separately as the project advances and that need is identified. Galen does have go-live resources available for upgrades, conversions, or go-live, so very often we kind of work that out as we're going through the project here. So issue resolution, post-conversion go-live, any issues that were identified that were unresolved are tracked. Typically what I find is that there's discussion at that point as to whether the issue was, something that should have been detected in testing and wasn't. Is it considered in scope to fix, or is this something kind of new and different that wasn't anticipated, and therefore maybe out of scope discussions take place, maybe some follow-up contracts to the conversion. This is all kind of the details that get worked out post-go-live. It's very common for issue resolution to take place over a week or 2 after the conversion. So let me just cover what gap mapping means then finally, with all this anticipation. So with all the data conversions, the team is working through the project from an extract that's typically taken near the beginning of the project from the production database of the legacy practice management or EHR system database. So one of the things to consider as part of go-live planning then is how to account for the new or changed data from the time that first extract was taken to the time of conversion go-live. And we've seen an example of where a client wanted to deal with that prior to conversion, but there are lots of possible approaches here. Another client might decide to go into the conversion weekend with the data from the original extract, and then as part of the conversion, the Galen tech could identify the gap data that didn't convert and create these differential mapping workbooks. And then at that point, the process, no matter what the timing is, whether it's before, during, or after go-live, the process is the same, basically mapping any of those new data elements that were identified, and then a follow-up conversion to be done. So the gap analysis can be done as post-go-live. At least one big consideration when working out the plan for the gap loading of data is how accessible is the data to the technical conversion team. In one of the conversion projects I'm working on presently, there's a tertiary vendor involved with the data extraction, and so this has a somewhat limiting effect on the gap load possibilities. Sometimes even there might be a fee involved for clients with multiple extracts. So yet one more thing that needs to be kind of talked about, what's optimal for these data extractions and subsequent gap loads. The mapping documents here that we're representing in the third bullet, especially for client support staff who will be supporting end users, making available the conversion documents, and we already mentioned this, but I just want to reiterate. So that would be the decision documents, the issues list, and the final mapping documents. Making those available, typically on the conversion server, we have a folder where we share, conversion documents with the client. Some of the documents contain, PHI, so having those documents available is a great way to provide the support staff with the ability to help themselves to information and understand the conversion. I mean, end users, providers, and nurses not typically going to get into those documents, although you can make them available, but it's really the support staff that need to be able to answer those questions, and very helpful to have access to those documents, so keep that in mind. And we are now at the end of our presentation, so let me just say, we have our little conclusion slide here. We've given you the overview of our conversion process, and I think you can see that there are many considerations and variables that go into conversion planning. So we hope that we've given you some helpful insight today. Mark started off the presentation letting you know that this would not take the full hour and a half that was scheduled, so we knew that we would have time to answer any questions you may have. If you've entered those into the question queue as we've been going along here, we're going to take some time to answer those. If you have a question now on your mind, please feel free to submit that. And we'll give you just a minute or so here, and then we'll see what we get.
Okay, so we have one here. This is Erin speaking. How do we make sure that the converted data triggers health maintenance alerts or appointment reminders? So it actually really depends on which target EHR you're using, because the setup is different for each one. However, overall, what we're trying to do is make sure that the data that we're mapping to the target system, that data actually will trigger the health maintenance alert. Usually they're set up where if you're, let's say, doing a colonoscopy, you'd want to make sure whatever procedure we mapped colonoscopy for into the target system actually will trigger that health maintenance alert. If it's, part of the scope, we'll definitely make sure that this is part of testing, definitely during full-scale or large-scale testing, and also make sure that during workflow testing that all the data triggers the right health maintenance alert.
Great. I'm going to take a stab at this next one, Erin, although this might be more up your alley. You talked about the testing, but here's the question. What is the best practice on the percentage of validation that should be done regardless of what PM or EHR application we're working with in conversion? Okay. Well, Erin had a slide that she shared where she kind of outlined the methodology, unit testing, small scale, large scale, full scale, and a lot of variability in there from client to client as to how that's defined basically. But I guess I would just say, and Erin, feel free to jump in here, unit testing, we're really looking to validate one of each type of data, of each data type, I should say, coming over. So that's the goal there, making sure that everything that has been mapped is able to convert successfully.
So, and I would say also, definitely during large scale, we're making sure that we map test one of everything that's mapped. We just want to make sure that everything is mapped correctly and that all the content is coming over. And also, Galen does have tools that you're able to estimate the testing sample size in order to make sure you've tested everything. So, like, we do a percentage of the overall population that makes sure that we have accurately tested everything. We do have tools that can help us figure out that sample size depending on how many patients you're actually converting.
Thanks, Bruce. I guess, I don't know, Erin, if you have any kind of guide or, I think really what happens with the large-scale testing and, looking at the total population of patients, the total number of data elements coming over, and then kind of coming up with a subset of that. It's a discussion, but, and I know that, a certain percent, like 25% sometimes, but let me say this, it can take an awful long time to validate even just one patient, so you have to kind of balance how much time and how many resources you have available to do the testing. So I just think it's hard to answer that just in one kind of pat way.
I mean, I think you want overall goals of populations and test criteria, but it obviously depends on, if you're, doing multiple rounds of full-scale testing and you have lots of end users helping you out, you'll definitely be able to, reach those goals. But if you're only doing large-scale testing and there's not many resources to help, right, and you're just relying on the main project team, you might not get as much done as otherwise.
Well said. What else?
Any other questions from people? Okay. Well, we appreciate everyone tuning in on this Friday afternoon, and we hope that helped answer any questions you have about the overall process of conversions and gave you guys a lot to think about in terms of things to consider before getting into a conversion and things to consider while during the conversion. And most of our Galen, analysts here can help clients walk through this process and definitely lead the way and address this stuff early on with clients.
Hey, Erin, can you just flick to the next slide? Do you have that? Because I wanted to let people know that standard with all of our webcasts here, we basically post the slide deck to our wiki and also the Q&A. If any, I think we'll stay on here for a little bit even if people drop off. Feel free to, but if you have any questions you want to post, we'll be posting the Q&A to our wiki also. So there's our website. Thank you so much.
Thanks, everyone.
Have a good afternoon.